Hello everyone, I'm Chamindu Gunatilaka from Cincinnati Children's Hospital. Today I'm going to talk about how we can calculate the breathing effect, work of breathing, in the neonatal airway based on imaging parameters. Many preterm newborns have airway or lung defects due to prematurity. Tracheomalacia is an airway condition due to dynamic collapse during breathing. If we compare the tracheal cross-section of a normal subject and a subject with tracheomalacia during inspiration and expiration, you can see there is a clear difference between the tracheal cross-section areas during respiration among the two subjects. We have shown previously that neonates with tracheomalacia require more energy to move air through the trachea compared to subjects without tracheomalacia due to the dynamic tracheal motion. We use dynamic data from ultrashort echo time (MRI) combined with CFD simulations to quantify the work of breathing in the airway. However, these CFD simulations are time-consuming and expensive. So the objective of this study is to find a relationship between CFD-derived work of breathing versus airway measurements such as tracheal cross-section area, tracheal length. For this study, we recruited 24 neonatal intensive care unit subjects and 12 subjects did not have tracheomalacia and 12 subjects were diagnosed with tracheomalacia. We acquire images using a neonatal size 1.5 Tesla MRI scanner with the following imaging parameters. We obtain the free induction decay waveform of the MRI, what we call the motion tracking waveform, which modulated due to the neonate's breathing and bulk motion during the scan. This figure shows the initial phase of the free induction decay waveform over a 6-second window, and colored waveform was obtained after removing bulk motion and smoothing the raw data. Note that each colored bin (blue, orange, red, purple) represents different breathing phases, that is, end expiration, peak inspiration, end inspiration, and peak expiration. After image reconstruction, we can obtain 4 MR images showing each breathing phase that capture the motion of the airway and also the lungs. You can see from these videos how the airway and lungs move during one breath. Here we apply two boundary conditions to perform CFD simulations. First one is the airway anatomy and motion. We segment the airway surfaces from MR images for each subject, and then we register all airway surfaces to acquire the airway motion throughout the breath. Here we use cubic B-spline interpolation to obtain the intermediate time points. As you can see in this video, you can see how the nasopharynx, glottis, and main bronchi moves during one breath. The second boundary condition is the airflow rates of the left and right bronchus. In a 16-minute scan, neonates takes about 1,000 breaths, and we determine the median waveform, which represents typical respiratory waveform. After segmenting the lungs from MR images, we can obtain the tidal lung volumes, and then we rescale the median waveform based on the tidal lung volume. Airflow rates were calculated by differentiating the volume curves. This figure shows how the airflow rates of the left and right bronchus throughout the breathing cycle. To perform the CFD simulations, here we use STAR-CCM plus CFD package. CFD mesh includes polyhedral cells in the interior and prism layers on the wall. Mesh size was 2 million cells and temporal resolution was 0.8 milliseconds. We found those values after performing a convergence study. We used large eddy simulation mathematical model as our turbulence model and no slip condition was applied on the wall. We can calculate the work of breathing if we know the velocity and pressure distribution during the breathing cycle. Here I am showing the velocity distribution during the breathing cycle of a subject with tracheomalacia. You can see due to the narrowing in the middle of the trachea and also at the glottis, there is a high velocity jet in this subject during peak inspiration and peak expiration as well. This slide shows how the tracheal resistive work of breathing changes with different airway geometric parameters in those 24 subjects. If we look at the y-axis, tracheal resistive work of breathing were normalized based on minute volume to obtain the tracheal resistive work of breathing per milliliter of flow. Now if we look at the top two graphs, minimum glottis cross-section area and maximum change in the tracheal cross-section area as a percentage, out of these two, minimum glottis cross-section area is the best predictor of predicting tracheal resistive work of breathing. Here the rho, which is the Spearman coefficient, was minus 0.58 and p-value was 0.003. Now, if you look at the bottom two graph, which is tracheal length and tracheal volume at end expiration, these two were not significant in terms of predicting work of breathing in the trachea. I want to emphasize here that even though I have not listed other variables in the airway in the trachea, that is minimum tracheal cross-section area or minimum diameter of the trachea, those variables are not significant in terms of predicting work of breathing. I can conclude that this study demonstrates patient-specific CFD simulations with MRI-based airway motion can provide clinically important information. The tracheal resistive work of breathing can be predicted based on geometric measurements of the trachea. The minimum glottis cross-section area is the best predictor of resistive work of breathing in the neonatal airways. Finally, I would like to thank my research group at Cincinnati Children's Hospital and collaborators from University of Wisconsin-Madison and Imperial College London. Thank you.